Thank you for allowing me to participate in the NTM. As Dr. Daly said, I am a bronchiectasis specialist, so I'm a pulmonologist as opposed to an infectious disease specialist. I want to give an overview of bronchiectasis. A lot of people have asked me specific questions, and so this lecture is going to be a broader generalization. And then if more specific questions come up, I'll try to answer them at the end. So I viewed what are some of the questions we want to answer during this lecture. And so what is bronchiectasis? How does one get bronchiectasis? How is bronchiectasis treated? And then how is this related to what we're here for today, non-tuberculous mycobacterium? And so when I'm in with patients, I often start with a big overview, like where's the problem? So in a normal healthy lung, we have three components to the lung. One is an airway system, which is comprised of trachea, which is the big windpipe, if you will. And then that enters the lung. And once it splits, that's called a bronchial airway. And that just keeps splitting and becoming smaller and smaller, like branches of a tree. That leads to the tissue or alveoli. Now, these are small, microscopic little balloons, if you will, of tissue. And so airway system to take airway out to fill the tissue. Once the tissue gets it, it soaks up the oxygen and puts it into the third component, which is the blood vessels. And the blood vessels drain all that nice oxygen-rich blood to your heart so you can pump it to your body to live. So the lung is those three things. Where's bronchiectasis? I bet you can guess. It's the bronchial airway tree. So bronchiectasis is not a tissue or a blood vessel problem by its nature. It is an air tube problem. So if we look at a normal healthy air tube, this would be enlarged and looking at it in a cross section or in a sort of longitudinal section. If you look what the Greek says, bronchos. So bronchi or windpipe and ectasis, that is always hard for patients to say, is ectasis, is the dilatation. So it's airway dilatation. And so what happens is there's a variety of causes we're going to highlight here in a moment. But whatever the cause, something has led to a dilation of the air tube and making it more tortuous. So it's not just straight anymore. And then this leads to mucus entrapment. And so this mucus plug in the air tube then can trap what? Infection, which is why we're here. So here are some facts about bronchiectasis. This number here of 350 to 500,000 adults in the US is vastly underestimating. You got to remember, we can only put people into the known if we actually look for the disease. And so this disease often is underappreciated, and that's because there's a lot of common symptoms to other pulmonary conditions that are often more thought of. So the condition's twice as common in women as compared to men. It is increasing in prevalence, so it's becoming more common as patients are aging. So, we're more likely to find bronchiectasis in somebody over age 60 as somebody under age 30. And then, these next 2 points I highlight because we're patients and families here today, right? And this is a disease that really leads to a lot of morbidity or a lot of illness. And these patients and family members, they have a lot of burden of going to the doctors frequently or even ending up in the hospital. And that's not uncommon. And that's different than other pulmonary diseases. And so how do we make a diagnosis of bronchiectasis? Well, one, we would only think of it in a patient if they had some symptoms that would make us go further. And so we have to think about what are the symptoms, and I highlight here a few, but on the next slide, we'll go over a little bit more. And then we want to think of what are the causes of bronchiectasis. If I have a patient with a certain disease that I know can cause bronchiectasis, that would make me think of looking for it too. And then the way we make the diagnosis is a CT scan. And so the next few slides, we're going to go over these three components. And so here are the common symptoms, and the percentages are what percent of sort of the registry patients have these symptoms. And so you can see the predominant symptom of bronchiectasis is cough. Many patients have cough. But if you look, not every patient that coughs does bring up mucus. And so there's even something known as the dry bronchiectatic patient, where they don't produce a lot of mucus. But cough and mucus are the predominant symptom of bronchiectasis, that mucus getting caught in those dilated airways. And then shortness of breath. Shortness of breath can sometimes be in patients who have even normal lung function. And it's because those mucus plugs in there give almost like a sense of heaviness when you're breathing through it. So I'll hear my patients often say, I just feel like a heaviness. I can't get a nice deep breath. And so shortness of breath is also a common symptom. And then fatigue and wheezing, but hemoptysis, what is that? That's coughing up blood. And you can see here, that's not a rare thing. When you think about it, it's 1 in 3, 30% almost. And I say that because a lot of patients, it's alarming, right? If you see, especially a teaspoon of blood come up, that gets your attention. And so, this is something we track with our patients. We want them to tell us if they're having hemoptysis, and trying to keep track of, how much is it? Is it just a teaspoon? Is it flex? That helps us. And then I have some patients that will have coughing up blood or hemoptysis as part of just their chronic condition. And it waxes and wanes over, some a little bit more at a certain time, and then it clears up. But then a few months later, it comes back, and that's part of the disease. That is not uncommon. What are the causes of bronchiectasis? So there's over 30 causes, and I'm not going to go into every single cause, but I put this up here to sort of highlight there are sort of big categories of causes. So you can see there's congenital, which means they were born with a condition that predisposes to developing bronchiectasis. And sort of one that a lot of people know is like cystic fibrosis. But there are others. And then immunodeficiency, that means low immune systems. So there are certain patients that either develop low immune systems, like patients who have had chemotherapy can have low immune systems, or some people are born with them, where they were born with an immune system that doesn't function normally, which predisposes to infections. And then that can cause bronchiectasis. And then infection, a lot of, you can see I have here Mycobacterium, and I'm highlighting it here because that's what this course is about. But when you take registries, both in Europe and US, the estimated cause of bronchiectasis being from Mycobacterium is like 5% or less, actually. Now, that probably undervalues it, because why? We can only make that diagnosis if we look for it. So sputum cultures are vital if we're trying to figure out if people have chronic infections. And a lot of times patients will come for a bronchiectasis evaluation and have never had sputum cultures. So when your doctors are trying to get sputum cultures, this is why it really is vital to, one, figuring out why did you develop bronchiectasis maybe, but also some of the complicating factors of having the disease, which is recurrent infections or chronic infections. So again, Mycobacterium is a cause, but it wouldn't be the most common cause. And then rheumatologic means autoimmune diseases. And these are things like lupus or rheumatoid arthritis, where the person's own immune system is attacking their body. Aspiration, so sometimes we'll do swallow studies on our patients, because if we can find that they're not swallowing appropriately and it's going down the windpipe, the trachea, that can go into the lung, and then that causes infections and can scar the lung. And I often hear this from patients, well, why are you ordering this study? I can swallow just fine. I don't choke. Well, if we knew all the time what was going on, we wouldn't have to order it. But I can tell you from ordering these studies, sometimes we're surprised, both me and the patient, oh, I have a little bit of swallowing problems that I didn't even know about. I don't know if Jeff King has talked yet, but he's one of our GI specialists. We also look for reflux. And so these two, aspiration, either from reflux material coming up or just chewing and trying to get the food down, can cause bronchiectasis sometimes, or at least complicate it and make it harder to control. And then there are, like I said, over 30 causes. So we said symptoms, thinking of different causes, but the CT scan is the key for making the diagnosis. And I tried to sort of give an example here of what we're looking at, which is if this is the patient, they're going through the CT scanner, and as they're going through the radio, it's taking slices of pictures, which would look like this. And so this would be as if the patient's lying down and we took a slice. And this would be roughly about halfway down the chest. And I know that because right here and here are the bronchial air tubes branching off the trachea to enter the lung. So air on CT scans, I want to give you a little bit of a background on a CT scan so you know when we look at these with you, what you're looking at. So air on a CT scan is black. Very dense things like bone are white. And so right here is the vertebra. These are ribs. And then this would be the sternum up here. This is a nice air-filled lung. And these white lines or dots are blood vessels. So this is normal. And this is what when we're looking at patient CT scans, comparing it to in our head. Okay, this is normal. Does their CT scan look normal? So this would be not normal. This would be an example of bronchiectasis. And I'm circling here in red, the sort of the key finding for us of bronchiectasis is everywhere there's a blood vessel, which is the white dot, an air tube is right next to it. They should be the same size. And if the air tube's bigger than it, it's too big. It's bronchiectatic. So these are examples of bronchiectasis. And we also look to see, is it as the air tubes go out towards the edge of the lung, they should get smaller. And if we don't see that, that could be a sign of bronchiectasis. So again, I'm not trying to make you all pulmonologists here, but I want you to be able to see, and a lot of people read things online. And sometimes people think, oh, if I have, cystic bronchiectasis, that means it's worse, or, it's just different shapes. There's different things that we use to classify the severity. And what we're looking at when we say it's cystic bronchiectasis is the shape is enlarged of the air tube like a cyst, versus cylindrical or tubular is just that the shape is more of a, like I said, tube, versus varicose, which is basically this right here. You can see it's sort of more wiggly or tortuous. So it's just describing what we're seeing, just so you know. It helps us think about different causes. That's why we note it, though. So what are some other testing that you or your loved one may get? Well, one, if we want to rank the severity of a patient's lung disease, we'll often do breathing tests, which are known as spirometry, or if we do a little bit more testing, it's called pulmonary function testing. And these are where the patient is blowing very forcefully out, and we're measuring that. And just because I know I have patients here, I want to just go over what a normal would be. So this is an example of spirometry. And this FEV1, that means when you were going blow, 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 in that first second out, how much air could you get out? A normal is 80 to 100. And that's just comparing you to a healthy control. And so if you were 50%, that means you're 50% of where you should be as compared to a norm. So it's half of normal. And so this patient here would be 92, which is in that range of normal. So I say that because your doctors may be telling you, oh, your lung function is 30%, 50%, 70%, 90%. That's telling me where you compare to a healthy norm. Lower numbers, more severe. Sputum cultures. I think from this day, you will know that sputum cultures are vital. I think that's one of the big things that Dr. Daly would be like, well, how could we not check a sputum culture? So I diligently do it because I've been trained well by him. Sputum cultures are vital. And I'll have patients that just cannot produce. And that's okay. Let's try. It doesn't hurt to try. But if we can't, sometimes we have to do bronchoscopy. Because if we see something on a CAT scan that could be infection, we'll have to eventually get some cultures from there. And bronchoscopy is where a pulmonologist has you come in like a colonoscopy, and we put you to sleep. And while you're asleep, we take a camera down into the lung to get cultures. And so we can get fluid from the lung. So that's what bronchoscopy is, another way to get more culture data, especially in those that have a hard time giving us sputum. And then I highlight here, not that I'm going to go into all these labs, I highlight this because there's a lot of labs that we order on our patients, and you could be sitting there and like, oh my goodness, look at all this blood they're taking from me. We're doing it for a reason. We're doing it because we're trying to figure out the different causes of bronchiectasis. If we go back a few slides, we said there's over 30 causes. So if we don't evaluate those causes, how will we ever know? And so a lot of these labs are geared at trying to figure out the cause of bronchiectasis. So it's not every single time we see a patient. It's more that initial evaluation. This slide is to really highlight that a lot of the things we do are based off of studies that are not approved. A lot of the things, meaning not approved for non-CF bronchiectasis. There are guidelines in other countries. Currently, the US, the big organizations, the CHEST and ATS, that's sort of our two big ones for pulmonary and infectious disease, of course, are working on guidelines, and those will be released. But a lot of what we do is geared either from the European guidelines or from the data or the information we've learned from our cystic fibrosis patients. And hopefully, as we get further and further along, more and more therapies for specifically non-CF bronchiectasis are being developed, and they're being studied, and we'll highlight that on the last slide. The reason that it is important to know the cause of bronchiectasis if we can figure it out. And why do I say if we can figure it out? It's about 40% of the time, despite doing all of that we just highlighted, those labs and the breathing test and the CAT CT scan, 40% of the time, we don't know why the patient has bronchiectasis. And so, but the goal and the reason we do all that is if we can find it, we can target therapy towards it. And so knowing the cause will help us know the treatment. And again, I'm not going to go through all the different specific diseases because that's sort of beyond this lecture, but just knowing that each one will have treatment. And I stop here, obviously, because this is the non-tuberculous mycobacterial conference. And so one of the causes is non-tuberculous mycobacteria. And if we can find that because we looked for it, because we got sputum cultures, we can then target therapy for that specifically with antibiotics. And then we talked about the rheumatologic. Again, I'm not going to spend too much on this slide. I put it up there mostly because if you're reading online or if you hear other people talking, they sometimes talk about the vicious vortex, the vicious cycle. This is really just how is the injury occurring in the air tube. But if you think about it, it's really saying there's infections are a problem in this disease. Airway scarring and distortion, like we showed on that diagram of the dilatation. Excessive mucus, like we said, it's getting caught in these scarred airways. And then inflammation. And I put this up because that's how we target a lot of our therapies towards each of these components. So those who have been on a lecture of mine know I always, or my patient, I say this frequently. There are 3 cornerstones to managing bronchiectasis. Number 1, airway clearance. If it's a problem with mucus getting stuck, get it out. And we're going to highlight on a few slides different mechanisms of airway clearance. Second, airway clearance. Third, airway clearance. If I could go down to 5, it would be airway clearance still. So Airway clearance is vital. And I do this, and I've done this for providers at different conferences, so I do this for physicians as well, and they chuckle as well. But it's vital. And I can't tell you how often this is overlooked or forgotten. And overlooked by whom? The doctors. We see patients all the time who will come for bronchiectasis evaluations, and I go, oh, what are you doing for your airway clearance? You're flying from all over and seeing all these providers. And a lot of people don't know even what airway clearance is. So airway clearance, the word is getting out, but airway clearance is vital. And I said overlooked and forgotten. The other team member is not just, we're a team, right? So part of it is the doctor, hey, I have a bronchiectasis patient, I need to get them on airway clearance. But who's the other part of the team? The patient and family, because this is very arduous, very time consuming. And so a lot of patients, it sort of falls off their to-do list, especially, when it's a more time consuming regimen. So components of treatment, we talked about, it's a problem of mucus entrapment. So we have to help get that out. Inflammation attenuation, which is just a fancy word to calm inflammation, calm it down. And then infection control. If we find infections, we need to think about that. And do we need to treat that with antibiotics? And the reason we target these three things, if we target each of them, not just one, we can help progression of disease, maintain better lung function, help patients' symptoms, keep them out of the hospital, and decrease the likelihood of more advanced disease and complications from that. It's like oxygen. So we manage bronchiectasis so we can help prevent these things. So if we said it's a problem of mucus getting entrapped, the first part is mechanical for airway clearance. And I'm not going to go into every single way. Again, that's beyond. And we have our respiratory therapist, Cheryl Torres, who's speaking later, who will go over some of these. But mechanical, now, you notice I put up here purposefully the diagram of postural drainage. And if any of you have been a patient of specifically Dr. Hewitt's, but also our infectious disease partners, they're not going to probably want a lot of their patients with mycobacterium doing postural drainage as the first sort of way to get mucus out of the lung. Because we're always worried if you put your head lower than your stomach, that you could have regurgitation and aspiration. So that's why I put that up there. But for some of my patients, I take care of cystic fibrosis patients that are all ages and they don't have reflux as their primary mode of disease. We sometimes do use that, but there are a variety of mechanical ways. And the key is that you use it. It is only effective if you use it. And usually we try at least daily. Whatever we pair, it's not a one shoe fits all. There are some people that certain ways of doing mechanical is uncomfortable. So we can't use that for them. So you have to listen to the patient. So we have to listen to you. And then you have to let us know if there's something that's, not comfortable about a certain therapy. And then, we have to re-educate a lot and involve our therapists. Like I said, Cheryl Torres will go over the different techniques here in a little bit. So there's mechanical, but there's also pharmacologic or medication ways that we can get sputum out. And a lot of times this is nebulization, which is a mist that you inhale. And it takes about 10 to 15 minutes, sometimes a little longer, that is either with salt water with different strengths. Sometimes we use this, it's acetylcysteine or mucomist. And then I just want to highlight, some of my patients, when they do these therapies, they get a little bit of bronchospasm, a little tightening of the air tubes, and they feel, boy, I feel some chest tightness and I feel wheezy and short of breath. It's really uncomfortable. So sometimes if we pre-treat with an albuterol substance, it can help mitigate, help relieve that symptom, and they can tolerate it. Sometimes patients feel that doing a little albuterol prior to an airway clearance, either with saline or an aerobica flutter valve, they feel there's a better result. But I have patients that they feel side effects from albuterol, it makes them jittery. And as long as they're not having the other complications of treatment, well, then we don't use it in them. So I don't want you to feel like we must do everything. And I say this because I know, there's different websites and Facebook and all these different things. Remember, we're all different. And so if somebody's doing one regimen, it doesn't mean you have to be on the exact same one, because we're trying to pair it to you and think about your side effects or what's best for you. So I've heard it all. I cough it up so I don't need airway clearance. I hear that one from patients. I do not get anything up when I use it, so I stopped. So this is like when I'm asking them, are you doing your airway clearance, all this? I use it when I start to get sick. So I'm nipping this in the bud, in essence. The reason that patients often do this is because, again, a typical airway clearance, even if you're doing it once daily, is easily about 30 minutes at minimum. And again, those of you that don't have the disease and are the family members, just know your loved ones it's a big commitment. This is a very arduous disease to manage for the patient and time consuming. And so it's easy to be, just like if we use working out, we're all supposed to work out and exercise. Last time I did that was about 4 weeks ago because I've been really busy. But with this disease, you can't do that also. So you have to be diligent, and it's time consuming. So it's easy to sort of come up with reasons that I don't know I have to do this. But if it's a problem of airway distortion, leading to mucus entrapment, leading to infection, it all starts with getting the mucus out. And I often tell patients, it's like brushing your teeth. I go, we don't brush your teeth like, oh, I've got gingivitis, let me get on that, I better start brushing them. You just brush them every single day, regardless if you think you need it or not, because you know it's going to prevent problems. And so you brush your lungs with airway clearance every day so you don't get bronchitis, so you can prevent it. Or a bronchiectasis exacerbation, which we'll go over in a second. So inflammation attenuation or decreasing inflammation. I put this slide on there. Again, I'm not going to go into all the data about why is azithromycin helpful. It's more to understand why a doctor may tell you, I want you to be on a daily antibiotic. Azithromycin is an antibiotic that's known as the Z-Pak, but a lot of times in bronchiectasis and other lung disease, we use it daily, not for its antibiotic properties, but we use it like Advil for the lung, if you will, an anti-inflammatory to calm inflammation. And it's not ideal, especially in patients with mycobacterium, because azithromycin is often one of the cornerstone antibiotics used to treat non-tuberculous mycobacterium. So if we have a patient who we know is growing mycobacterium, we would not recommend this. And that's why it's important to get cultures, because we don't want to breed resistance and then find out later, oh, this person has mycobacterium and we've now had them on azithromycin for like 2 years and we bred resistance. So we have to be cautious. And the good thing is there's some new therapies that might come out that help sort of replace this to help with inflammation. So controlling infections. What are exacerbations? Let's start there. Bronchiectasis exacerbations, probably for a patient would be thought of as bronchitis. Oh, I got sick. For a doctor, it is any time that the patient has more symptoms than their norm. And I say norm because I know having bronchiectasis will create some level of symptom for each patient, be it some hemoptysis, be it cough, be it the mucus, shortness of whatever it is, there will be a norm for that patient. But if they have more cough and more mucus or more shortness of breath that's sort of sustained over a day or two, then we would think we should intervene so that we don't have the patient get worse and end up with a big pneumonia. So that is an exacerbation, a worsening than the patient's norm, where a doctor has to sort of intervene with some treatment, which is typically antibiotics, because often these patients are having infection. And so we make sure we address exacerbations. Chronic suppressive inhaled antibiotics. again, this is just to highlight why doctors may recommend certain things to you. Some of our patients have chronic infections with different types of bacteria, and they keep having exacerbations despite doing their airway clearance very diligently. Sometimes we'll put them on where that neb machine, they're nebbing, putting in through their lungs, in other words, an antibiotic, inhaling it. And they do it on for a certain amount of time, be it 2 or 4 weeks, off, and then on, and then off, and potentially indefinitely. And so inhaled antibiotics is another tool that some of our patients need to help just calm down these chronic infections. And then, this whole conference is about non-tuberculous mycobacteria. And it's always sort of a chicken and an egg, which is, did non-tuberculous mycobacterium cause the bronchiectasis? Or did non-tuberculous mycobacterium just be found in someone with bronchiectasis? And I highlight this as a lot of what Dr. Daly and Dr. Kasperbauer and Dr. Griffith, all the infectious disease doctors, Dr. Eddy, Dr. Haas, they're really trying to weigh, is this finding in the sputum something that we need to treat because it's causing problems? Or did we just find it because they have this chronic condition? And it's there, but it's not causing them a problem. So again, I highlight that because not everybody that we find this bacteria of non-tuberculous mycobacterium, do we say you need to go on treatment. It's a judgment. And that takes testing and time sometimes. So just to highlight that. So how do we monitor our patients? I always say there's 4 things that we need to monitor. One is how does the patient feel? You have to tell us what's going on with you. So we have to listen. That's 1, symptoms. 2, what is their lung function doing? So over time, we'll want to check those breathing tests to see, are things stable, improving, declining? So lung function over time. 3, we also want to check sputum cultures because we'll never find any chronic infections if we never look for infection. So sputum cultures. And then the last thing is imaging. We will do CT scans at different intervals, and it depends what's going on with each patient, when that interval is. But over time, we'll follow to see if we're seeing more bronchiectasis on the CT scan. And then again, a big part of monitoring our patients is sometimes we need to re-educate or increase airway clearance. And so having that respiratory therapist as part of our team is key. And so this last slide is just to highlight some of the future treatments that may be coming out. The one that's probably the closest is the top one, which is dealing with neutrophilic inflammation. Neutrophils are a type of white blood cell, and white blood cells are often recruited to areas of infection. So if bronchiectasis is where there's sort of chronic infection in there, you can have a lot of white cells going there, and it revs up inflammation, which is redness, swelling, irritation of the tissue, which over time can damage it. So calming down inflammation is one of the key components. And there's some new therapies going to be coming out targeting that, hopefully at the end of this year or next year. So soon. So biologic agents, these are different shots that we use to calm inflammation in certain patients with different types of inflammation. Nebulized, again, breathing in a mist of immunoglobulins has been looking at. What are immunoglobulins? Antibodies. So actually giving the patient antibodies that they inhale into their lung. This is a therapy that is a way to help thin mucus and calm inflammation. That's a study that just was going on, and it will hopefully be moving forward. This is a different, a little bit more novel, off in the future maybe. CFTR is the CF protein, the protein that causes CF. And so if CF is a disease of bronchiectasis, can helping that protein work better help mucus in patients with bronchiectasis even without CF? That's been looked at. And then just different types of antibiotics so that we can treat these infections in our patients better. So I'll end with that. And I think I timed it pretty well, 10:30.
Thanks, Steve.
Do you see any correlation between celiac disease and bronchiectasis?
Oh, I can restate it though. She was asking, is there a correlation between celiac disease and bronchiectasis? And celiac disease is gluten sensitivity, and or I gotta say inflammation in essence. It's where you are making an antibody to that protein gluten, which then leads to a lot of inflammation and problems in the gut, intestine. And so it's not, Jeff King is right here, who's a GI doctor. I don't know of any direct, like this is known to cause bronchiectasis, unless you do, but I do have patients that have celiac that have bronchiectasis. But not a direct known correlation that it is definitively a cause of bronchiectasis.
Back. Yeah, let me just, the reason we need you to speak in the mic is for the people online.
I can restate it. She was asking what percentage of my patients could I estimate have celiac? That's a tricky question because I said sensitivity, which is wrong, because it's truly, when you say celiac disease, an antibody response. There are many patients that have celiac sort of sensitivity intolerance where they know, hey, I went on a gluten-free diet, it really helped me, but they don't actually have an antibody causing the disease. So that's tough to say, but celiac disease is actually pretty rare where you have an antibody. Celiac sensitivity is not as rare, but overall it's not common. I will say that. It's a small percentage.
I have a couple of quick online. She has a question. Oh, too quick. Does COVID cause bronchiectasis?
So I have seen severe COVID patients. An example would be a patient who was on a ventilator for weeks and they had so much inflammation, it scarred the lung, which that scarring can pull on the air tubes and distort them, making bronchiectasis. So yes, but very, very rare. Cases that are not like outpatient, no.
3 versus 7%. Why do we recommend 7?
So he's talking about the hypertonic saline or sodium chloride that we nebulize in for airway clearance. Comes in 3, 7, and 10. There's normal saline, which is 0.9. All have some level of proven benefit, not robust studies, but there's all, and we have found that 7% is usually a little bit more effective at getting the mucus thinner and coughing it out. So it helps airway clearance. I have very, very, very few patients that can tolerate the 10% because of throat irritation or the airway spasm. 7%, many can, but there is a real number of patients that have troubles with even 7. And so we do the 3%. And then very, very few just don't tolerate it at all. And we try other alternatives like the mucomist we highlighted up there.
Are you monitoring at all the patients who have had COVID and the impact that that may be having on symptoms such as hoarseness and voice loss?
You know, we have a post-COVID clinic here that we were running, and a few providers were tracking the data. Long symptoms, the hoarseness isn't as common. Fatigue, chronic cough, some shortness of breath, some people who develop like an asthma, almost like syndrome. Those are the most common of fatigue by far is the most common of sort of long COVID. Hoarseness, not as common, but.
Yeah, I had a quick question on the future treatments for inhaled ascorbic acid. Where in the pipeline is that at right now? And how long do you think that will take to, to get some resolution on the efficacy?
Efficacy, probably not that long. If you're talking about when would it be available, that would probably be, if we estimate 4 years, because right now we just finished a pilot study. And then you have to actually design a study that shows benefit. Then you have to expand that out to a larger study. That's easily about 3 to 4 years. And then you have to present that to the FDA to get FDA approval.
Yeah, so the top line results are coming out from the first trial. It's not just ascorbic acid, it's glutathione also. Okay. And it's going to be presented, we hope, at the World Bronchiectasis Congress in the fall. And because the top line results look good, we hope that means there will be investors that will allow that company to take it to later phase studies. Let's take that one more question and then we're going to move on. But you're going to be here at the break.
Oh, the break?
Yeah.
What time is that? At the end of the day? I may not. I have another meeting.
Oh, okay.
But.
Okay, hi. Can the damage done to the lungs by bronchiectasis be reversed or improved through any of these therapies like good airway clearance? Or have you ever seen bronchiectasis go away? Like it's present for a while and then you don't see evidence of it anymore?
Yep. And so bronchiectasis by its nature is a chronic condition. So if you have somebody that has a CT scan, it's really mild, and you then see another scan that, it's not mentioned. Sometimes we overread it because the airway is more prominent if it's inflamed. So it sort of shows up like a whiter circle and we're like, oh, it's bronchiectasis. And then as the inflammation goes down with treatments, then it doesn't look as prominent. But that's not really bronchiectasis. That's bronchial wall thickening. If you have bronchiectasis with that distorted air tube that I sort of showed, then that's not reversible. That's chronic. How we manage the patient can definitely help them do better and feel better and prevent progression of that bronchiectasis. So treatment vital, but if you have an air tube that is bronchiectatic, it should be always there.
Okay, Steve, thank you very much. That was outstanding.